Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Josh. How are you doing today?
I'm good, Dennis. Thanks. How are you?
I'm doing well. So, as customary on the podcast, would you mind doing just a real quick introduction of yourself?
Sure. I'm Josh. I was a Ranger medic many moons ago, and then grew up and went to med school. And now I work through the Army in a level 1 intensive care unit in Colorado Springs.
Perfect. So today I would like to talk about vent training and essentially how to do it right.
Easy.
Yeah, it's super easy, right? I've gotten a lot of different vent trainings from different people. And generally, I would say it's almost enough to cause me to make a lot of mistakes, right? So I get the basic definitions, roughly an hour of didactic. We go over how the lungs work. We go over tidal volumes, rates, PIP pressures, peak inspiratory pressures. We talk about PEEP and how great it is. And then we do some hands-on stuff where we turn the vent on, we set the heights correctly, and essentially we connect it to some rubber lungs and watch it inflate and everything's good, and now you're TFR trained to go out and probably kill a lot of people. So
Make some mistakes. Yeah.
Right. Now, when I do connect it to at least living things, generally, it's a pretty horrible experience. Alarms instantly start going off. Panic ensues. And I'm wondering, why am I screwing this up, even though I've been trained? So what am I doing wrong?
Let's have some more background for this scenario. What are you treating? And are they spontaneously breathing? And what are they sedated on? And what's your airway?
Sorry about that. You couldn't hear that, right? Good.
Sorry, how's the dog?
Yeah. So again, what am I screwing up?
So let's do more clinical background in the scenario. What are you treating? Are they sedated? Are they spontaneously breathing?
So generally, coming in out of the field, we've got hemorrhage control, we've got the airway managed, we've given at least initial pain control. Something is wrong with their chest. We've initiated some kind of resuscitation. We've managed the chest to at least T-tri-C level, so needle Ds or finger Thor or something like that. And then we've gotten, a unit of blood on, and their SpO2s continue to fall. And, I'm starting to think this guy needs some kind of... Hold on.
Pause. Still muted.
Yep. Start that over again. All right.
There we go.
Okay. We will get through this. All right. All right. So, Josh, I've gotten lots of, I think halfway training on the ventilator. Usually it's a didactic block for roughly an hour. We go over basics as far as, tidal volumes, respiratory rates, PEEP, peak inspiratory pressures. Then we go into some kind of hands-on where we're talking about, how to turn the vent on, how to set up basic parameters. And then generally you're TFR trained and then getting pushed out. Now, when I do that same thing on a living thing, generally it goes horribly. And I am so sad about myself because the events immediately start alarming. The patient is obviously very agitated. Everybody else is agitated around me. And I know I've done something horrible, so I immediately ripped the vent off the patient and, understood like that was wrong. Don't ever do that again. So just to kind of set up maybe a situation, I think it'll be a lot easier. Multi-system trauma patient, some kind of penetrating trauma to the chest. I've done hemorrhage. I'm coming in off the field. I've done hemorrhage control. I've managed the chest to some kind of T-Tri-C level, whether that be needle decompression, a finger Thor, or something like that. We've initiated some kind of resuscitation where they've gotten a unit of blood. Systolic pressures are above 100-ish, right? And SpO2s are still very low. End-tidals are high. Patient is breathing rapidly. And I just got this sinking feeling I'm going to have to do some kind of ventilatory management. That it's not the hemodynamics that's the problem. There's something wrong with his lungs and I need to fix that. So that's why I'm trying to put him on a vent just to free up hands, right? We've done it with the BVM where it's okay, but I need those hands. So we want to put him on a ventilator. So what is it I'm screwing up? What am I doing wrong? And how am I supposed to do this properly?
Patient improved with the BVM. So you demonstrated that when you
not great, but it's definitely come up some. So maybe SpO2's in the 60s. Now he's in the high 70s, low 80s.
I would get him normal if you can with the BVM before you try to put him on a ventilator, because it will take some time to troubleshoot and appropriately set up the ventilator. You could have somebody else handbagging him while you redo the settings on the ventilator, right?
Okay.
And then when you connect the vent, what's going wrong? What's alarming?
Yeah. So it'll say, breath assist, breath assist, breath assist, which is essentially saying you're wrong, you're wrong, you're wrong. None of those alarms really inspire confidence in what you're doing. So, I don't know. I don't know what I'm doing wrong.
Which ventilator is this?
Save 2.
Okay. So patient is trying to breathe. The ventilator won't allow the patient to breathe. And so solution is to sedate to achieve ventilator tolerance or synchrony. Sedate with opioids or benzos with fentanyl or midazolam.
Okay.
Because ketamine will not decrease the respiratory drive and will not make the patient any more tolerant to the ventilator. Okay. The SAVE 2 operates on... go ahead. The SAVE 2 operates on what's called continuous mandatory ventilation. So it has a set rate that you set, and the patient can't get a breath any other time besides when it's timed. So if you set a rate of 20, there'll be a breath delivered every 3 seconds, and that's it. If the patient wants to breathe between breaths, that will just cause patient agitation, ventilator desynchrony, and alarms, as you know.
So I guess with the narcotics, how much opioids? I'm petrified of opioids. I don't want him to burst into flames. I just want this to be as easy as possible. Yeah. So you get a little bit of sympatholysis and decrease your catecholamine drive when you give some level of opioids and benzos. And so you do have to be cautious. I guess how much... I don't want to give you a dosing protocol because I'm not your medical lead, but I would say starting with anywhere between 25 to 100 micrograms of fentanyl based on body size. And you want to treat pain too, right? So traumatic injuries. I think that's a reasonable starting dose if you appropriately resuscitate the patient. Okay. So we're resuscitating. It's ongoing, right? Yeah. So vital signs are normal. You said end-tidal CO2 is good, and his systolic is above 100. If his heart rate is in the 80s to 90s, I think you're good to give 25 to 100 mics of fentanyl. Okay. So I've given that. It's still not great. Obviously, you can continue just giving fentanyl or morphine or whatever opioid I have. I guess at what point is it now, have I achieved what I need to achieve? Is it just when the alarm stopped going, or? You can add benzos there, so you can give a dose of 2 to 4 milligrams of IV midazolam is probably fine to add next. And the answer on the SAVE 2 is you have to sedate the patient to the point where he has no respiratory drive. Okay. Otherwise, if he tries to trigger breath, then you're going to get an alarm. Okay. All right. So we're given the drugs, things start improving, right? End-tidal is still pretty high, like 70s, right? SpO2 just on the finger monitor there, it's okay. We're, maybe in the low or high 80s, low 90s, somewhere in there. Obviously, I can't just leave the end-tidal being sky high, right? It should be at 40. So, like, I guess which one do I address first? The okay SpO2 or the really high end-tidal?
If he's oxygenating well, which it sounds like he is, or well enough, then I would address the end-tidal. And so you do that by adjusting the minute ventilation.
Okay, so how do I do that?
That's your rate and your tidal volume. And generally the tidal volume is fixed, probably 8 cc's per kilo of ideal body weight. Shouldn't go above that. I don't think in this acute phase that you need to go below that. Okay. I know you guys have talked about the ARDSNet protocol on this podcast. I wouldn't start instituting ARDSNet until 12 to 24 hours of illness. I would stay with 8 cc's per kilo tidal volume initially, especially if the guy needs the minute ventilation. And so you have to increase his respiratory rate.
Okay, so
blow off CO2.
Okay, why rate first and not just volume? Because it seems like the more air I push in, it equals more good.
Tidal volume should be fixed. It should be fixed at 8 cc's per kilo. If you give more than that, there's a danger of overstressing, causing barotrauma, volume trauma, more damage to the lung than you already start with.
Okay. And so how much would you say I set at 12? We start at 12. What would you go up by?
I would probably address 2 to 4. If his end-tidal is 70, I would go up to 16, from 12 to 16. But I think that's not going to kill him. If it's not changing rapidly, it's not going to kill him. And so you have time to address cautiously. You will see a change in your arterial CO2 30 minutes after you adjust the minute ventilation on the ventilator. And so you could adjust your rate by 2 to 4 and then wait 30 minutes to expect to see that change reflected.
Okay.
Does that make sense?
Okay. It does.
Oxygenation you see within 5 minutes. So if you change PEEP or FiO2, you see that change reflected in 5 minutes on general blood gas. The CO2 takes 30 minutes because of the excess CO2 load in our body.
Okay. Which kind of goes into my next question. So, I increase the rate, within, 5, 10, 15 minutes, I'm starting to see things slowly start moving. Is that okay? Or do I need to move things, right away?
I think you have plenty of time. I don't think that's what's going to kill the patient.
Okay. Cause I would say impatient. I want these things to be, I want numbers to be
scenarios are
done faster.
Yeah.
So, and I'm getting graded on everything. So, is it okay to just make it go faster?
You don't want to overshoot, especially if you have some level of brain injury. You don't want to overshoot. You don't want to get the end-tidal CO2 too low.
Okay.
And so I would tell your instructor to cool off and find other things to do. That's what I would say in that scenario. Hey, bro, I've addressed the minute ventilation. That's going to fix the end-tidal. I'm going to do other things.
Okay.
That's what I would say.
So it's okay to fix end-tidal over hours.
Yes. Yeah, that's what I do, right? I'm in the ICU. I see somebody's blood gas is off. I address the respiratory rate and I go do something else.
Okay.
You can draw down the blood gas in 30 minutes to an hour.
Okay.
Or watch your end-tidal on your EMA.
Okay. So I'm not super comfortable with SpO2 in the, let's say, upper 80s. I want it to be 98. That's where it's supposed to be. That's what all the books say to do.
It's too much.
What? Why?
It's too much.
That's what all the books say. So obviously you're wrong.
Yeah. I've been wrong before, that's for sure. I would say your goal is 92 to 97 and you can accept it low of 88%. And some would tell you, depending on what your FiO2 is, some would tell you 85% is okay. The thought is there's some degree of lung toxicity from too much oxygen, hyperoxemia in the alveoli. And if your SpO2 is higher than 97%, your PaO2, your arterial oxygen, could actually be as high as 200, 300. You don't know how high it is with an SpO2 of 98. But if your SpO2 is 92 to 97, that is a pretty good correlation. Your arterial oxygen is where you want it to be and not too high.
Okay. Well, that's helpful. But I don't have any oxygen. I don't have any oxygen tanks. at the very best, I would have, a Soros or some kind of oxygen generator of some kind. And generally those are pretty lame, right? When it comes to oxygen, I can get like 3 liters, which is better than nothing. But at best, I would have something like that. But this is the PFC podcast, and we always think about worst case scenarios. So I have no oxygen. And no supplemental oxygen. Yeah. How do I help his SpO2 to get him to that 92 to 97?
So let's make sure he's tolerant with the ventilator. He's not asynchronous, so you're delivering every tidal volume as planned.
Okay.
Your arterial oxygen will be affected by your end-tidal CO2, and so make sure you're normalizing your end-tidal CO2. That means ventilating enough, getting enough oxygen in and out. If he has lung damage and you think it's diffuse, you have a reason to suspect it's diffuse, he has blast injury or like bilateral trauma, you can try to increase his PEEP gently.
Okay.
You're probably starting with a baseline of 5. You can come up 8 and then 10 and then 12, knowing that if you haven't adequately resuscitated him, too much PEEP is going to cause cardiac collapse, decreases left ventricular preload, and so he won't have any cardiac output. But with diffuse lung injury, PEEP is a good thing to improve oxygenation. It improves your mean airway pressures, and so that improves your oxygen. And if you're sitting a guy for 6 to 12 hours, you've got a normal end-tidal. He's PEEP to the point where he's still hemodynamically stable, and you think that more PEEP will make him worse. You can put him face down. Prone patients will improve oxygenation and decrease lung stress. Okay.
So just because on the Save 2, the maxes I can get is 10. 10 of PEEP is the highest I can go on the Save 2. So, I come up, to 8 or something like that. SpO2, sometimes it'll go up. Sometimes like absolutely nothing will happen, especially when I have like a penetration injury. I found that PEEP, it kind of helps a little bit. But then there's definitely like a plateau where it just stops. And, I'm a numbers guy. I always want to get to that, perfect, let's say 95, right? Or higher. Is it okay to just like keep going as high as I possibly can on the PEEP?
If you have focal lung disease or penetrating trauma, then you want to minimize PEEP. PEEP can actually over-distend the good lung and then under-distend the bad lung. And so when an alveolus is over-distended, you actually decrease the capillary blood flow to that lung. So too much PEEP in focal lung disease can be bad.
Okay.
And in penetrating trauma, if you have a traumatic pneumothorax, too much PEEP will increase the amount of air that's coming out of that hole in the lung.
Okay.
And can make your hemodynamics worse. And so minimize PEEP in focal lung disease.
Okay. So definitely some kind of thoracic management is ongoing, right? One needle decompression does not fix everything.
Does not fix much, yeah.
Okay. So probably somebody like that, it would be wise to put a chest tube in.
Yeah, if somebody's on the ventilator and positive pressure ventilation, they should probably have a chest tube.
Okay.
If they have lung trauma, they have pneumothorax.
Yes. Yeah. So kind of just walk, we kind of walked through a scenario. We've talked about adjustments and things like that. But let's kind of, if you wouldn't mind, critique or build some kind of training for ventilator use and management. What kind of things do you think somebody like, obviously I don't know what I'm doing, right? What kind of things do I need to know before I even think about playing with the vent?
I think when I do a Vents 101 class for residents and fellows, I include discussion of ventilator modes. So the continuous mandatory and the Save 2, which will cause agitation because there's no patient trigger. Versus I think the 731 has SIMV as well as like a assist control mode. Do you want to talk about the differences of those two?
Sure.
Okay, so I'll keep my opinions to SIMV to myself. That's a surgical mode and has no benefit. But what SIMV does is it's a volume control. So you set a rate and say your rate is 20. Every few seconds, the patient will get a set tidal volume. And then the synchronized intermittent part of SIMV is that there's a pressure support backup when the patient wants a breath. So patient triggers, and then he gets some level of whatever you set of support. So the ventilator will blow a little bit of extra pressure to help his breath, but it doesn't determine the tidal volume. So the patient gets the tidal volume based on how much pressure you're giving, as well as on how hard he can pull and what the compliance of his lung is, meaning the ability of his lungs to expand, which will be worsened in things like pneumothorax, hemothorax, pulmonary edema, blast lung, which would cause diffuse pulmonary edema. And then that's opposed to assist control, where any breath, whether it's triggered by the ventilator based on a time or triggered by the patient based on patient effort, gets the same tidal volume. So SIMV, you get a pressure support breath if you ask for a breath. Assist control, you get a set volume breath anytime you ask for a breath.
So SIMV sounds like it's the better one. But I have a sneaking suspicion it's also difficult.
I think both of those modes are difficult. Any sort of volume control mode can be uncomfortable for the patient. Any sort of controlled mode where the ventilator is shipping a breath, that can be uncomfortable for a patient, right? It's a sensation of air coming into your chest through positive pressure, as opposed to me choosing to take a breath. I think it's uncomfortable.
If you had a beginner mode, which would you pick?
Volume control.
Assist
control. Volume control, assist control. And then you can add SIMV if your patient is quite tachypnic, and so is triggering breaths frequently, and his end-tidal is dropping, so you think he's developing respiratory alkalosis. You can put him on SIMV so he doesn't get quite as much support with each patient-requested breath. But aware that he may be tachypnic because he has a profound metabolic acidosis from hemorrhagic shock, right? And so try and assess the reasons for why your patient is tachypnic. If he's tachypnic from pain, you should treat that. Before decreasing ventilator support, you should make sure you're addressing resuscitation and also pain control.
And I think that's another thing that guys kind of forget, especially when you get a ventilator management class. It's only about the ventilator. It's only about changing these parameters, makes the patient do this. And people tend to forget, like, this is like a global problem. Like, you have respiratory, or you have hemodynamic issues, you have pain issues, you have respiratory issues on top of all of those things, and just kind of picking, like, you have to target one initially, optimize that, and then kind of move on to the next.
Recognize tachypnea as a problem of something else, right? A result of something else rather than a primary problem for the most part.
So other than modes, what other are the big things we need to go over?
We talk about the peak and then the plateau, which I think you've talked about in previous podcasts. The peak inspiratory pressure, if you draw a volume control waveform, looks like a shark fin, which I'll try and draw. Let's see if this works out. My paper turning.
Yes,
so
I can see that.
0, and you have some level of PEEP. And then this is a pressure waveform. So the pressure gently rises until it's achieved at that tidal volume. And that's your peak inspiratory pressure. And the pressure goes back to 0 and then next delivered breath. So your peak is a reflection of both the compliance of the lung and the need for pressure to expand the lung, as well as pressure to get through airway resistance. So if you have a small tube, a crike, like a 6-0 crike is a very small tube, or somebody with some sort of obstructive lung disease, COPD or asthma, or a fixed airway obstruction as a result of a trauma or tumor, that peak can be higher, but doesn't actually reflect the lungs. And so you can measure a plateau on some vents, but not the SAVE-2, which actually reflects the ability of the lung to distend. So your peak plat is usually a little bit lower. And the difference between your peak and your plateau pressure will reflect the compliance of the lung. And so high peak, low plateau is a resistance problem. So I'm blowing through a small tube, or my patient has an airway obstruction somewhere. Whereas a high peak and a high plateau is a lung compliance problem. So I have pulmonary edema, I have pneumonia, I have pneumothorax, I have hemothorax, I have effusions.
So I guess what could be the difference, to tell me, hey, this guy has an airway obstruction problem that potentially I could fix, or this is a, diffuse lung injury like blast lung that I have to be extra careful about the volumes and the pressures that I'm putting in.
Yeah. I don't think you can measure a plateau on the SAVE 2, and I don't know that you can measure a plateau on the Impact 731 either.
Yes, you can measure plateau pressure on the Impact. Has a specific button for that. But on the SAVE 2, the best I can do is if there are no alarms going, if I hit the enter button, it will tell you the measured PIP and the measured PEEP. But that's all you get.
That's all you get. Yeah. So the Impact, you do an inspiratory hold. So you deliver a breath, and then a ventilator keeps that amount of pressure going to expand the alveoli, and that's your plateau pressure. It's the pressure needed at the airway opening to keep the alveoli expanded. Which is a reflection of compliance, right? So if that's high, you should be thinking about, in trauma, probably diffuse lung disease, blast lung pulmonary edema, or like some sort of lesion, mass lesion, pneumothorax.
Okay. Is there a normal distance or a normal difference between the peak inspiratory pressure and the plateau pressure?
In volume control, that difference is going to depend on your on resistance of the tubing. If there's no intrinsic airway resistance, it depends on the tubing and then the patient's lungs. In pressure control, and I think the Impact is actually a pressure control vent. It's a pressure regulated volume control. So it delivers, I don't want to get too complicated, but it delivers your goal tidal volume within the confines of your allowed pressure. So most of the time they'll probably tell you to allow a peak of 30. And so it will deliver a tidal volume as long as the pressure doesn't go above 30. But if you develop a compliance problem or a resistance problem, then it will deliver a pressure of 30 and your tidal volumes will start to shrink. And that can be your key because it's pressure regulated. They'll call it volume control, but it's a pressure regulated volume control. But on a pressure control mode, it's a flat waveform as opposed to this shark fin waveform. And so your peak and your plateau are almost the same. That's your pressure control waveform, which is probably what you're used to seeing on the Impact.
Yes.
And so then they should be the same unless there's an airway resistance problem. Okay.
Does
that make sense? That was a lot.
It is, and I'm not that smart.
Don't sell yourself short. I mean, this is an hour-long class on its own.
Yes. And that's one of the things. It's like we get guys, it'll be a guy like me. Like I've read some books, I've talked to some people, I have a little bit of experience, but not that much. And I am now asked to give training to brand new people who have zero training. So I have more than them, but probably not enough. You know what I mean? And that's where you get a bunch of people who are really dangerous with a piece of equipment that they think that they're confident with, but are not.
It can certainly be a murder weapon.
Yes, it can easily be.
When things go well, you're probably well equipped to handle that. But when things go wrong, you probably just don't have the experience to know what to troubleshoot.
Right.
So that's why you have the advisor line.
Yes. So other than, your modes and some basic, this is what PIP is, what other things are really important to know?
The concept of compliance is important. I've said that a few times. And you can think of lung compliance as a balloon, right? So when you start to blow a balloon, it's really hard, right? There's a lot of resistance to flow. And then when you get it to blow up, it becomes much easier, right? And then as it's too full, then the compliance again goes down. So that's your kind of compliance curve. And so a balloon that's like hugged from the outside will have worse compliance, right? Because it's harder to inflate. You need to give more pressure to inflate. I don't know that you need to think of any calculations. That's just kind of what compliance is. And so you can imagine how a pneumothorax would decrease your compliance, right? Because there's this fixed lesion that the lung can't expand against. It's like something hugging one part of the balloon.
Right. Can you recognize that on a ventilator? A compliance problem. What kind of alarms would start?
The plateau. So your peak alarm would start to go off because the peak would rise with the plateau, and then you'd check a plateau pressure and see that it's high.
Okay. And then you would know, reassess the lungs, right?
Yeah, these are the things I should think about. Yeah.
Okay. All right. Other than compliance, because I see all kinds of dials, especially on the Impact vent. I see all kinds of dials and all kinds of numbers, and all of them are inviting me to change them.
Come touch me. Yeah.
Yeah. But I don't know what any of them are. So I know I shouldn't, but I want to.
Sure. Yeah. You can go.
What
probably
is safe to? Yeah, what is safe to? What is safe to change? What is not safe to change?
You can probably adjust the flow. If you have a patient who's dysynchronous with the ventilator, you can either sedate them out of dysynchrony, which is the easy answer in the ICU, and in the prolonged care environment. If you're going to be sitting on somebody for a long period of time, like more than a couple of days, the more you sedate them, the more you're going to impact their outcomes on the other end. As their illness starts to resolve, they're going to be sicker for longer and take more time to get off the ventilator as a result of the sedating infusions. And so sedation is not always the best answer. And so some people have more intrinsic respiratory drive as a result of pain or injuries, or just that's who they are. And so you can try to adjust their flow, which is probably the I time on a pressure regulated vent. So you give them a shorter I time that's more flow. So that's the rapidity with which the breath is delivered. That can satisfy some patients' air hunger or respiratory drive. It doesn't always get you the best results, but that's one thing you can play with, right? That's one of the knobs. I can decrease the I time. If they have obstructive lung disease, which are unlikely to encounter in a trauma environment, then you decrease the I time to prolong the E time, give them more time to exhale. But in somebody with respiratory drive, you decrease the I time. You can probably adjust the trigger. You can have a pressure trigger versus a flow trigger. Flow triggers are easier for patients to meet. And so I generally and that's for the patient delivered breath, right? Patient draws in and then ventilator delivers a breath. I would set that to flow, and like 3 to 5 liters per minute is a reasonable flow trigger. And you can torture a patient too if you don't want her to breathe. You can increase that flow trigger, make it harder for them to breathe, and they just end up needing more sedation. So not the right answer. I'm trying to think of what else I would want you to modify. I don't know. Can you think of any knobs that you're looking at that?
I mean, there's 4 of them, right? And there's a constant menu on the side. So, we talked about, in order to fix, SpO2 problems, change your PEEP, add oxygen to it. We talked about fixing your end-tidal issues with tidal volume, less so than your rate. Rate is more safer to change your rate than it would be your volume. But I'm sure that as long as your pressure, your PIP, your peak inspiratory pressures are below 30, and you're not getting good satisfaction out of your rate, you could slowly come up on your volume.
Yeah. If your plateaus are less than 30, I can introduce the concept of driving pressure, which is the difference between your peak and your plateau. So this straight line here is your driving pressure. There's some thought that a driving pressure higher than 15 is probably correlated with worsened mortality, with causing worse lung damage. And so, I mean, you can increase your respiratory rate as high as 34.
But that doesn't seem right at all.
That will give patients time to exhale fully. If you go higher than 34, you start running into breath stacking. You can't fully exhale before you get a new breath delivered. So I would say increase your respiratory rate up to 34. And if you still have a minimum inhalation problem, if you still have an end-tidal CO2 problem, so yeah, bigger issues. You could try to increase your tidal volume, but I would not.
So, start off, if you're starting up the vent, start somewhere between 12 and 20. And it's okay to go up above 20?
Absolutely. If the patient requires it. You can go as high as 34,
And you're just watching, making sure that your flow is going back down to 0 or whatever your PEEP is set to ensure that they're fully exhaling before the next breath.
Yeah, the flow waveform should get back to 0.
Or whatever baseline is.
It will get back to 0 because the flow shouldn't be affected by your PEEP. So the flow should get back to 0. And speaking of flow, that's probably one of the other things you can adjust is your flow waveform. The classic rectangle waveform versus more of a shark fin kind of that. I don't think you need to mess with the flow waveform. I would just take whatever the default is, which is probably rectangular. But that's probably one of the knobs that allows you to adjust.
So I'm getting the deep, dark suspicion before I change anything out of basic parameters, other than, my changing my rate, changing maybe my PEEP and FiO2. Once I've gotten those base set, I probably should be calling somebody.
If you can, yeah. I would cover up before you just try to do things. Yeah. RTs go to a long school for that to manage the ventilator. Yeah.
Okay. Yes. I think that's very smart.
Recognize that these patients are on ventilators, right? And so they're not normal. And so it's okay to go beyond normal parameters. They're likely to need abnormal parameters because they're not normal by definition, right?
Yes.
You and I breathe 8 to 12 times a minute, but we don't need a ventilator.
That's true.
These patients didn't do, and so they probably need to breathe faster.
Okay. So as far as setting up a class, we talked a little bit about compliance. We talked about some basic stuff, basic settings, basic measurements. Are there any in sedation? Are there any other kind of parameters that I should be expecting from a vent class?
If you have guys who are have been 18 deltas for a while, managed some patients on the ventilator for a while, and are looking for more vent knowledge for prolonged care specifically on the PFC podcast, you can start to talk about trigger, cycle, and limit.
Okay.
Have you heard those before? Are you familiar with those?
No, never have.
I don't want to go too much, right?
That's all right. We
started. So a trigger is what tells the ventilator to deliver a breath. Okay. And so in volume control mode, that's the set respiratory rate, and then patient's flow, right? Same for pressure control mode. In a pressure support mode, like SIMV, it has the volume control. So the trigger is it's time, right? Every whatever seconds it delivers breath plus flow. A cycle is what tells the ventilator to stop a breath. And so on a volume control, that's delivering the set volume. So I trigger based on time, and then I stop my breath based on volume. A pressure control is triggered based on time and then cycled based on pressure, right? It slowly ramps up to the delivered pressure. Oh, sorry, I said that wrong. A pressure control mode is also cycled based on time. It delivers a set pressure for a set amount of time and then stops, and you get a volume based on how much pressure is delivered and how long it's delivered for.
Okay.
And then pressure support mode has no cycle. It just delivers the pressure when the patient tells the ventilator to.
Okay.
That's speaking English so far.
Yeah, I'm tracking.
Okay.
I think.
And then limits are alarms. So like the PEEP is a classic limit. Say your PEEP at 30, it won't deliver a pressure higher than 30, and the ventilator will alarm when you do that. On a support mode, like apnea would be an alarm. So you allow the patient to be apneic for 20 seconds, and then the ventilator will alarm at you.
Okay.
Yeah.
So just as an instructor, because I have limited knowledge, I have limited ability to provide good feedback to my medics. If you had any advice for instructors, what things, what do I need to know in order to provide good feedback, and how would I be a better instructor for those things?
I think you need to recognize when you're doing something that's not realistic, right? So when I get an advisor call about a multi-system trauma patient who has a cric and is on anesthetic dose ketamine and is synchronous with the SAVE-2 with an end-tidal of 35, I'm like, bullshit. The ketamine is not going to make that patient tolerant with a ventilator, which only delivers on a mandatory mode. So you have to, and I don't know how to replicate that in real life, except by telling the patient and telling the student, hey, your patient is dysynchronous, he's coughing, and the ventilator is alarming. And so force them to reach for the opiates or benzos, or to ask for an impacts and 731 vent to be delivered. Recognize that ketamine won't do that, won't decrease the respiratory drive. And then recognize that your unresuscitated trauma patient, right? If you're calling me and the blood pressure is still in the 80s, the end-tidal is probably not going to be 35 unless you're hypoventilating. It's going to have decreased cardiac output, and so that will be reflected in a lower end-tidal than you would expect just based on the respiratory rate. And those patients are going to need tachypnea, so try and adjust your vital signs according to the resuscitation.
If you wouldn't mind, I would just to ask on that, because that's another kind of area that I see guys struggling with, both students and sometimes instructors, is what actually happens in trauma and your end-tidal CO2. So if you wouldn't mind just quick running through that.
Yeah, I've heard it on a couple other podcasts, but it's always worth a refresher. End-tidal CO2, as measured at the airway opening, is a reflection of the lungs delivering CO2 to the airway opening to the mouth, and also a reflection of the heart delivering CO2 to the lungs. So is there blood going through the right side of the heart to send to the lungs is the right side of the heart functioning to send blood to the lungs? And then are the lungs functioning to get CO2 out? In most under-resuscitated multi-system trauma patients, you probably expect a lower end-tidal because the heart is not delivering all that much CO2.
Okay. I mean, does pain affect that? Does the patient, because when they, like a trauma patient, just out of experience, like they are breathing like really fast, you know?
Or they're breathing fast because they're in pain, because they have respiratory disease, or because they're under-resuscitated and they have a metabolic acidosis and have to breathe to compensate for that.
All the above.
Yes, to all the above. So do things simultaneously, right? Treat pain, resuscitate, and then treat lung disease to the extent that you can. And recognize that early on in the scenario, your end-tidal is unlikely to be normal because there's all these things going wrong that will affect it.
Right.
Tachypnea will lower it. Shock will lower it.
Yeah. You know, and then as you're resuscitating, like, why does it jump back? Like the end-tidal CO2, say we're at 30, right? And we start resuscitating, and we're just rocking it with the blood going in.
Just killing it.
Right? And, you know, but that end-tidal, like it starts climbing and climbing and climbing, and you think like, okay, we're going to stop at 40, but we don't. We just keep climbing and climbing and climbing, and it gets like really high. Is this something that now I need to, of course, bag the patient to get it back down to, 40 where it's supposed to be?
Over time, like we talked about earlier on, right? So recognize that you've done a good job, and the climbing end-tidal is a reflection of your improving the cardiac output. And so that's a success. And then the next steps, you have time to ventilate that patient back down to a normal CO2.
Okay.
Over the next 30 minutes to 2 hours.
Do I need to bag him? Because it should correct on its own as long as he's got a good airway, he's breathing appropriately.
Yeah, if this patient's not intubated and is breathing on their own, then you can see what that patient does.
Okay.
And, give him some time.
Okay.
If he has primary lung disease and requires assisted ventilation.
Yes. Yeah. If there's a SpO2 issue that isn't resolved with resuscitation, and he's got some kind of mechanism for thoracic injury, then would be an indicator to do some kind of vent management?
Yeah, if he doesn't otherwise have an indication for ventilation, if he's not in a respiratory failure, doesn't have an airway obstruction, then you can give him time to recover on his own.
Now, I've heard that end-tidal CO2, whatever that number is, isn't necessarily a real reflection of what's happening in his body. That number is probably the lowest the CO2 is in his body. I guess why would that be?
I have a slide from my fellowship director about the difference between like a venous blood gas CO2 and an end-tidal.
Okay. You don't want to draw that?
Because end-tidal, I have to go back and look at it. I don't remember. I didn't prepare for that.
That's all right.
Because end-tidal is a reflection of the lungs as well as the heart, and your CO2 pumping around your body doesn't reflect the heart as much.
Okay.
Like a CO2 on a venous blood gas doesn't reflect the heart as much.
Yeah.
Does that answer your question?
I think so. The way I was picturing it, and it could be 100% wrong, that as somebody descends into shock, their end-tidal may be falling, but it's building inside their body. And as you start resuscitating, as you start opening up those vessels, and they're actually now perfusing their body, there's a certain amount of debt that needs to be paid, and it's paid through just time of them off-gassing CO2. And that's going to be your respiratory acidosis. I think the rate or the amount of time that they've been down is building up a metabolic acidosis, and it takes time for the body to convert that metabolic acidosis into a respiratory acidosis to then come back out of the lungs. Is that right? Or is that
I can agree with that for the most part.
Okay.
I can buy that for the most part, yeah. Because you have ongoing metabolism, which is producing CO2 while it's not being returned to the lungs by the heart.
Okay.
In a
I guess
state.
where am I wrong? Not a challenge. I meant just honest question.
I wouldn't say wrong. I'm just not sure about the metabolic acidosis being converted to respiratory acidosis. It's because respiratory acidosis is a function of hypoventilation, right? I'm not breathing enough to get rid of the CO2.
Right.
And so that metabolic acidosis, all the CO2 building up in your body, not being delivered back to the lungs by the heart, is not a function of hypoventilation. It's just a function of a heart that wasn't delivering CO2 back to be expired.
Okay.
Does that make sense? That's
yes.
a good question.
The lungs can only affect respiratory acidosis or alkalosis, right? Based on its rate. I guess what other, so if I have a metabolic acidosis, which somebody who is in shock, I think it's safe to say he probably does.
Yeah.
What ways can I affect that? And should I even bother affecting that? Or is it just a thing that the body will sort itself out?
It's a resuscitation problem, right? So lactic acid, which causes the metabolic acidosis and shock, is a product of low tissue oxygen, right? Shock is low tissue oxygen delivery, tissue hypoxia. And so the lactate is a reflection of anaerobic metabolism. And the solution is to get more oxygen to tissues by resuscitating, by repleting the tank, making sure the pump is working.
Okay. I mean, is this something that other than I can give him blood and I can measure that with his blood pressure. If I really want cool points, I'll get a Foley and get his urine output up.
Yeah.
Between 0.3 and 0.5 cc's per kilogram per hour. And, but as far as, targeting a metabolic acidosis, is that even something that I need to worry about? Or as long as he's resuscitated, his blood pressure is good, want cool points, his urine output is great, the body will just kind of fix it itself. For the most part. And that's like an endpoints of resuscitation lecture. You don't have a blood gas, right? So you can't actually check their lactate or check their base deficit, which you can see on blood gas. And I think end-tidal CO2 is the best tool you have out there. Know that if somebody's been in shock for as little as 15 minutes, can do it. But in your young, healthy guy, probably as long as a couple of hours, you can get a kidney injury, which is why it helps to track urine output. And a kidney injury, which can develop in the setting of shock and then can recover, but take time to recover, can cause its own metabolic acidosis as the kidneys fail to hold on to bicarbonate. So you get a non-lactic acidosis. Am I speaking English? Okay. Yes, I think so.
So if you're on day 2, if you're in hour 36 of a resuscitation and a guy had oliguria for several hours yesterday in the setting of shock, and then you resuscitate him and now he's urinating normally, he can have an ongoing metabolic acidosis for another couple of days because his kidneys failed to hold on to bicarb in the setting of that injury. And so you got resuscitated to the point where he has a normal lactate, but still may be tachypnic because he has an ongoing non-lactic metabolic acidosis.
Okay. Is that something, because we do have, where we're getting iStats. So we can, I think one of the cartridges is a Chem 8. So it would give, I don't know if it, up top, definitely, it can give you your gases. I'm not sure if it gives you your lactate or not. I can't remember.
But it should be a base deficit.
Yes, it will. It's going to tell me like this is out of parameters, right? So obviously that's something I have to fix. But in reality, is it something I actually have to fix, or as long as I'm still hitting my marks with, urine output and blood pressure, and his end-tidal is good and his SpO2 is good, I'm starting to get the feeling that the enemy of good is perfect, and I start changing too many things and trying to just get it just perfectly. I could end up unraveling the whole thing.
Do too much, you don't have to make things perfect. Do you accept mediocrity? Absolutely,
yes.
Especially in an austere setting with multi-system trauma, accept mediocrity. You don't have to make those numbers perfect to keep your patient alive and keep his organs functioning.
Good. So I've hogged up the entire conversation with all the things I want to know. Is there anything that, from what you've seen or from your time on the advisor line heard of, what, I guess for the instructors, what would you want them to set up, I guess, like scenario wise, to make things more realistic so that when the students are calling you, you're not having to say, actually your patient is coughing and he's not tolerating the vent, and you're just unraveling everything that the instructor had done for him. What things are like ridiculous that you've heard that, now makes this whole situation awkward?
Most of it is very well done.
Okay.
I think that the students will often do the cool guy stuff, right? And then
Yes.
I'll start reminding them of the ICU nursing stuff, because they're also the ICU nurse when it's just
Yes.
them out there. And so do wound care, because you haven't told me you did any wound care. You put an amputation, or you put a tourniquet on the amputation, and then next step, right? So once you've addressed everything, your patient is stable, then start to do the ICU nursing things. If your patient is
Okay.
immobile and heavily sedated, you need to roll that patient every couple of hours to prevent pressure injuries. You've given me an undefined exfil time, right? And so you could be there for a while. So do your ICU level nursing stuff.
Okay. Because
make
the
sure you're
majority
tracking
of
your output.
ICU nursing things I see is they put a blanket over them.
Really? Have you done 12-hour shift with ICU nurse? Yeah. I mean, they should be rolling the patient every 2 hours, training vital signs, doing hourly to 4-hour assessments of like mental status of the patient. So reduce your sedation, make the patient up, see where they're at. If you're intubated, I don't think it's a big problem with the crike, but keep the head of the bed elevated to minimize the risk of a ventilator-associated pneumonia, which can happen after like 48 hours.
Yep, suction. You need to suction not only the airway, but suction the mouth. Turning, actually assessing your IVs, making sure you're flushing them consistently, just so that they stay patent, because I see lots of them, IVs going bad just because they've not done anything with them in a while. They don't
put a lock on and ignored.
Yep, they put a saline lock on it, and just kind of assume that it just is forever patent when it's
there.
not.
It's in the vessel,
right? Yeah. Converting those tourniquets. I mean, you should be converting those tourniquets within the 2 hours for certain. But guys, I think it's, I would say, almost universal when they think nursing care, they think like put a blanket on them, put some nice music on,
wipe some butts.
Yeah, wiping butts, which I'm not going to do. There is, guys, I think underestimate, like even after you've gotten him stable, like you've done all the exciting things, you are going to be constantly busy with padding the patient, rolling the patient, suctioning the airways out, assessing injuries, irrigating wounds, if not necessarily every day, at least every few days, depending on the injury. Like you are just constant.
You should look at that every day.
So you are constantly busy documenting, watching, adjusting medications. Speaking of medications, I've seen a lot of times where it's just like, we want them sedated. They sedate the patient. And, I look up in my book, okay, it says, 2 mgs per kg per hour of ketamine. We do that. He goes down, which is perfect for me because he's not complaining or moving or doing anything.
Done.
Is it okay once the scary things are over with, is it okay to slowly turn down those medications to just see like, where is this guy at? Or should I just leave him out and be happy with what I got?
I'd say it's mandatory to reduce the sedation to see where he's at.
Okay. And
every 4 to 8 hours, and depending on what else you have going on, you should reduce sedation.
Okay. And I reduce it to, what am I assessing for?
Depends on what his injury pattern is, right? If he has a brain injury, you should keep him as minimally sedated as possible so you can fully assess all 4 extremities and pupils at a minimum. Like, can you follow commands on all 4 extremities?
Okay.
Is your pupil still symmetric? Do I need to be thinking of an expanding mass lesion that I need to intervene on?
Okay.
If he's not brain injured and he had a normal mental status going into it, then you should just wake him up to the point where he can follow commands.
Okay. And just check, hey, you can follow commands. Like, do I need to now adjust my goals? Like changing him from a sedated patient to now just an analgesic patient? Or is it okay to be like, I actually like it a lot more when he doesn't talk to me. So, take off sedation. I don't say take off sedation, but reduce things, get my assessment, and then quickly put him right back under.
Minimize sedation to the extent that he will tolerate it. If he's ventilated, he probably needs some level of ongoing analgesia or sedation.
Okay.
But otherwise, reduce that. And every patient will have their own threshold for like how much they need to tolerate the ventilator, and plus their injuries, right? And so decrease that to the extent that they can stay comfortable.
Okay. But it's 100% okay to turn things down. He starts to panic a little bit. I do my assessment and then put him back.
Yeah, absolutely. And you should, you can teach your guys that CAM ICU is a delirium assessment scale.
Okay.
If you're sitting on patients for a prolonged period of time, they can develop delirium, which will increase their duration of critical illness.
Okay.
Meaning that once they finally get to an ICU, how long they'll have to stay there. And so decreasing sedating meds and then frequently reorienting them. So every time you wake them up, like, hey, today is this, you are here. This is why you're here. Reducing delirium.
Okay.
That will help them out.
Okay.
And the CAM ICU is a validated scale to assess their delirium.
Nice. Is there anything else that you think we need to know in order to not kill our patients and actually have an easier time until we can get him off to somebody who actually knows what they're doing?
No, I think as far as I can tell, based on my consults and talking to you guys, are doing a great job. I'm not aware of any like reports of the SAVE-2 actually being used in prolonged field care for human casualties.
So far that I know of anyway, most of them are transport things. But I do think it's something we probably need to know more than what we do. Because unfortunately those transport times, especially if you're looking at conflicts going on around the world, those transport times are getting longer and longer. Those durations of holding on to people are longer and longer, and you're going to be stuck. And it's behoove you to actually know what you're doing or know more about what you're doing in order to actually just take care of those patients.
Yeah. If it makes the 18 deltas feel any better, my ass is clenched on a routine basis in the ICU, and I'm surrounded by a team of experts that I can lean back and be caught for the most part. And you're out there alone, so it's reasonable to be afraid, but prepare yourself as much as you can.
Yeah, cool. Well, thanks, Josh. I really appreciate it.
Thanks for your time.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.